All right, so welcome everybody. We do have some important information we want to share with everybody today as we go ahead and get started. We do have a session coming up on February 16th, which is going to be an extended session. We are going to be covering human trafficking, training for healthcare professionals and support staff. So we wanted to make sure that you were aware and that you could mark your calendars appropriately. That session is going to start about 15 minutes earlier. So we're going to start at 12:15 that day, and it's going to go about 15 minutes longer. I will be sending information out for that as well ahead of time, but that is also a session that is meeting the TMB requirements, and it is 1.5 credit hours. So we'll provide more information on that as we're coming up to that. So this is the family medicine grand rounds for today, January 26th. I have put the information and I'll post it again here in the chat box, but the event code is listed there for you. Please make sure that if you do want CME credit, that you do that before midnight tonight. If you have any issues with that, please do let me know. On the next slide here, there are some instructions. I have the wrong date and the wrong code on there, but I'll put again the correct information in the chat box. But please make sure that if you haven't registered, you send your email to the phone number there. And then after you've registered, all you have to do is put attend and then the code number for today, which is 10087615. So if you have issues, again, just contact me and I'll be happy to help you out with that. Next slide. We are going to go ahead and get started here. We do want to make sure that you have muted your microphone as we get started here. If you could also please remain attentive and engaged in this session. Towards the end of the session, I will be putting in the link to the evaluation form. If we can help provide feedback for the presenter on their presentation today, we'd really appreciate that. So we want to thank you in advance for those things. This is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AHEC, and our department's mission statement is there for you to read. CME transcripts are available if you're interested in viewing your transcript. You just need to go to the CME website. The address is listed there, and from there you should be able to see which sessions you've attended and received credit for. If you do have any questions, please feel free to reach out. Their email address is there as well as the phone number. You can also feel free to reach out to me as well. Along with CME transcripts, you will need that CME transcript if you do want to also claim your AAFP credit. For those of you who are members, you just need to contact the AAFP with your transcript. But if you have any issues, their phone number is there. And you're, again, more than welcome to contact me. We also want to make sure that we do note that it is our goal of these sessions to address the nationally established physician core competencies that you see listed here. So those are there. If you have any questions about that, please feel free to reach out. And I just want to make sure we take a moment to let you know that Dr. Shi and Dr. Reimers have no financial relationships with ineligible companies to disclose. So today we have Dr. Shi. She is going to be discussing for us the association of low value testing with subsequent healthcare use and clinical outcomes among low risk primary care outpatients undergoing an annual health examination. Her preceptor for this presentation was Dr. Reimers, but she is our academic chief resident, third-year resident with our program, so I'll let her get started.
Thank you, Nicole. So today I'd like to discuss this article with everyone here. This is one of the top 20 research articles in 2020 as selected by the American Family Physicians Annual Journal. So this was published in 2020, July 1st issue of JAMA Internal Medicine. So pretty long title, but when we get into it, the finding of the paper is pretty straightforward. Okay, so before I go into more detail, just want to remind you what are poems. So these are summaries of research that is relevant to physicians and their patients that meet one or all three criteria. So address the question is faced by primary care physician in day-to-day practice, measures outcomes important for physicians and patients, including symptoms, morbidity, mortality, quality of life, has the potential to change the way physicians practice. So just a little bit about the background. Before that, these are listed as the objectives. Hopefully by the end of the talk, we'll be able to understand what we define or we think are low value tests and what are the consequences of ordering or starting these tests, the care cascades associated with these low value tests. And then the main message of the association, which is demonstrated in this article, the 3 low value tests with the subsequent care among these low risk outpatient annual exam visits. And third, but not last, is also limitations. At any study, research study, there's always what you can draw conclusions from the study as well as there's limits, right? What's the next step? Well, we can go from here. What we can do to take into action, what can we do as individual physicians? So lastly, I'm going to go over a few recommendations from a Choosing Wisely campaign, which AFP is a partner of, and the USPSTF. So before I go into that, Dr. K was already asking, how do you define low value care? So the value here is the key point. All the third years in my class probably already gone through this in our practice management block. How do we define value? So value is the quality over cost equation. So quality, what do we consider quality? So will be the outcomes of patient care, right? Either improve their quality of life, decrease morbidity, mortality, and also on the other hand, we can reduce the cost. That's what we look at on the value-based care model, what the value means there. So low value care literally just means these care are not equating better patient outcomes. And in some instances, the harms may outweigh the benefits. And these also cost money. And overall, it's not helping the healthcare system in general. So here I listed some numbers here. It's based on some articles done recently that it's estimated these low value cares are costing about $75 to $100 billion annually in the United States. So there are a lot of efforts has been emphasized on how to reduce these costs. So one of the initiatives is the Choosing Wisely campaign. So this was first initiated or launched in 2012 by the American Board of Internal Medicine Foundation Consumer Report. So their idea was to have all the professional societies and healthcare providers take the lead in defining and motivating the efforts to reduce the use of low value care, therefore can decrease the use throughout these campaigns. However, since the launching of the program, there are a lot of recommendations have been put out there. The use is still quite frequent or prevalent. So not only these care were delivered or created, as the cost of ordering these tests or offering these care, there's a downstream cascades coming from the initial test. So we're not looking only at the initial decision making of delivering this care. We're looking at a domino effect of the whole care cascade. So that therefore the economic consequences of these low value care can be exponential. So there are a lot of proposals are being made when they're doing this. Every 5 years, they're reviewing the Choosing Wisely campaign, what we're going to go from here in the next 5 years. So the ones from 2017, there are several proposals are put out there. One of them is shifting the focus to identify these high priority clinical targets, i.e. those low value tests, so for quality improvement purposes. So although these were all the efforts been put out there, the large scale changes is still lacking. So that brings out the question of this current article. They were looking at more of a large scale quantitative analysis, trying to see if there's evidence that some of these low value cares are associated with subsequent additional care, i.e. those care cascades. So the tests they had picked are chest x-ray, ECGs, and pap smear. So there are proper clinical indications for these tests, correct? So I just wanted to kind of ask people in the audience here, if you can give me some reasons, why would you order one or any of these tests at all to some patients you see in the clinic on a daily basis? If someone can volunteer, I just want to make it more interactive, so it's not only me talking. So this is more of a, I think it's relevant to us, although maybe it's not as frequently used. I mean, these low value cares, because we kind of being smart and always following the guidelines and recommendations. But if you can just have a discussion with me, that'd be great. Volunteer, Randy?
Maybe an EKG if a patient's heart rate in clinics, in the 120s and they've never had that before, and you listen and it's irregular to kind of diagnose AFib or something.
Yeah. Anyone else?
Chest pain.
Yeah, great.
Chest pain.
Teresa. Yeah, so I mean, like EKG, when you're seeing a patient, they have chest pain, they have like substernal chest pain on the left side, and they're considering MI, definitely chest X. I mean, EKG is indicated, X-ray, chest X-ray on top of that too. So there are proper indications or appropriate indication. These tests are not low value in those instances, right?
And Dr. Shi,
yeah.
So Carolina Gutierrez said chest X-ray for chronic cough. And then Rodolfo Irby raised the question of what defines low value.
Yeah, so the definition is it's kind of, when I put it on top, these are a general term. So it depends on when you use it, when you are using it. Like what patients are you using, in what circumstances. So I'll get into a little bit more detail about how this paper defined these tests in those visits or care duration is considered low value in the second. I didn't go into the literature to see a kind of official definition. I'm sure Choosing Wisely had that somewhere. If I can find it, I'll provide that later, because they are coming up with a list of up to 27 low value care or tests in their recommendations. But overall, the idea is they're not improving the outcomes. In some cases, harms outweigh the benefits, and they're costly. Okay. So let's go to the next part, which is kind of just telling you what the study design and methods they're using in this paper. So this is a Canadian study. So they're using a population-based retrospective cohort study. So they're using the data they have used for the analysis are from administrative data. So it's not a EHR, EMR kind of a health record data. There's more of a similar to kind of billing type of data. So the time span they looked at is from April 1st, 2012 until March 31st in 2017 over the course of 4 years in Ontario, Canada. So they picked the 3 tests like I was talking to you guys earlier, but they defined is the chest radiographs for patients at low risk for cardiovascular and pulmonary disease. So I'll get into a little bit more detail when they say low risk. The second test they chose is the ECGs for patients at low risk for cardiovascular disease. The third one is, this test is somewhat different than the other 2 because we are using it frequently for screening purposes, but when they define them as low value is that pap smear was used for women younger than 21 or older than 69 years at low risk for cervical cancer, which is outside of the window we normally screen for cervical cancer. Okay, and then I do want to point out is that when they did allude even in their methods that there is this assumption from the study group that they chose the encounter type or these index events where these tests were ordered during their annual health examination. So they're having this assumption that this is going to be a routine service involving a healthy patient with no apparent medical problems. So presumably low risk patients. And then a primary care physician that is meant to be an opportunity to discuss preventions, for example, cancer screenings relevant to the individual's patient's medical history and lifestyle. So they're assuming these visits are involving healthy patients with low risk, because the billing was also associated with that visit that way as well. So they do have this assumption throughout their analysis. Okay, so let me introduce to you what are the 3 cohorts they're looking at. So the first 2 are both adult patients 18 and older at lower risk. The first one for X-ray is, for the chest X-ray is the low risk for cardiovascular and pulmonary disease. The second cohort is adult patients at low risk for cardiovascular disease. And the third one, like I mentioned, it's outside of the window and low risk for cervical cancer. So these are defined now. And then they further, they define what is exposure. So basically it's when these low value tests are ordered or initiated. So they define is either one of the, at least one billing claim associated with these tests on the day of or within 7 days after the annual health examination. Okay, so that's, they define the exposure. So the comparison group, the control group will be the ones did have an annual health examination without these low value care testing ordered, or a billing claim associated with these tests being ordered or appeared in the data set. Okay. So the next one, they're looking at what are they measuring? Oh, so the main idea is looking at the care cascades after these index events. So for all of the 3 different cohorts, you can see that the chest X-ray cohort, so they define the primary outcomes as either having a pulmonology visit, that's a specialist referral, or invasive testing, the bronchoscopy. Or the third one they looked at is the abdominal or thoracic CT. So these are, they're looking at the window up to 90 days from the index event. So they even expanded the CT scan up to 180 days, given sometimes there is some delay in getting these tests scheduled. And for ECG groups, they're looking at a specialist referral. It's a, that's indicated as an outpatient cardiology visit, a TTE exam, cardiac stress test, or cardiac catheterization with or without coronary angiography. And the PEP cohort, they define it, this window is a little bit longer given some of the recommendations for repeat of PEP smear. It can be in 6 months duration. So they're looking at, again, a gynecology referral or outpatient gynecology visit, a repeat follow-up PEP test, or colposcopy. So, and then they're also looking at secondary outcomes, which they think is even will be less prevalent than these primary care cascades. So in the chest X-ray cohort, they're looking at pneumonectomy or lumpectomy. ECG cohort, they're looking at coronary revascularization procedure. For the PEPS cohort, they're looking at the hysterectomy. So these time frame they're looking at within the year after the index index visit. Additionally, they're also looking at the hospitalization rate and ED visits, as well as death. So those are included in the secondary outcomes. So it's interesting that if you think you ordered any of these tests as an initial screening, not indicated test, what can happen? What are the possibilities can happen to the patient had received the initial test, right? So these are within the normal, I guess, outcomes you can consider. These might be happening. In their supplementary data set, they also included a pulmonary function test, some additional tests in the outside of what they have mentioned in the analysis, but that overall it didn't change the cascade pattern too much. Okay, so just want to get into a little more about what can be the variables that determines whether some patients get this test, some patient doesn't, right? And then some physician might order it, some may not. And also some other, what are the covariant or confounders that are contributing to the differences in the occurrence of how frequent these low value tests were ordered. So they are looking at patients' socioeconomic characteristics, including age, gender, income, whether they're rural versus urban dwelling, zip code where they reside, and the comorbidity index is more like a RAF score in our terms, how sick these patients are, frequency of hospitalization, ED visits, and frequency of physician visits, things like that. So they do consider these as possible covariant that influence whether they get the test or not. So physician factors was also included or considered, including how many years has this physician been out of a medical school, out of training, the gender of the physician, location of the medical school, the training location, whether the practice the physician is at has fee-for-service type of a payment structure versus capitation, and also the population practice population size, how many patients per physician kind of ratio, and how many physicians in the billing group, etc. So all these are possible confounders of why how frequent these events are happening. But in order to kind of eliminate or eliminate these confounders influence on the outcomes, so what they have applied is called propensity score matching methods. So they're trying to come up with a cohort having similar makeup of all the covariants in comparison to the ones that are getting screened. So one-on-one, if this patient has, let's just go back up for a second. If this cohort has an age of, say, 50, a more male predominant, more rural, lower income versus, the control group having similar makeup in their demographic information, whether when we match all the variables to about the same balance, were there any association in the outcomes related to the index event? So basically that's what the approach they have taken. So this is a very commonly used matching methods. So the idea of that is to minimize confounding based on covariant before estimating the association. So they did this matching before they actually did the analysis. I'll get into a little bit more detail whether this matching was successful or not, so we can appreciate from some of the result tables in a second. And the absolute standard difference was used to ensure there's a balance after the matching. So the threshold they had used is a 0.10. Okay. And then after that, the outcome measures, the way they had used the statistical analysis that I applied is called McNamara test. So basically this is looking at the marginal probabilities of the corresponding between the screened versus the unscreened. So the parameter they had used is they call the these three measurements: the RD risk difference, relative risk, and attributable factor. So the risk difference is the risk in the screened minus or remove the risk in the not screened. So when we say the risk, what does that mean? So it's basically how likely the event is happening in the screened group versus the not screened group. So we're saying how likely these outpatient referral is occurring per 100 patients after the index screen. Compare that or subtract that, actually the difference between the screen versus the non-screen. So we're looking at the difference between the two screens. And then if you do a ratio of those, will be the relative risk. And then lastly, they're trying to see what proportion of these events are attributable because they are getting screened initially. So that's the bottom line. Okay. So we're going to go into the graphs or the results portion of the paper now. So this is showing how many patients they're starting with and how many patients they're able to identify meeting the criteria for, I'm sorry, this is a little bit slow, small. So are at the low risk for these diseases. So they are starting over 5 million for the first cohort at the beginning. So how they define the low risk is that they're eliminating a patient we know are higher risk. So which they have known diseases in the cardiovascular pulmonary disease, or they have a complaint, even though without a diagnosis, or they have any pre-existing conditions that makes them have increased risk, basically. And they are also removing the ones that are not within the age range or having other risk factors. For instance, they have said in the long-term care facility, so that more or less indicating they're higher risk at the baseline. So I'm just gonna show you on with the graph on the left as an example. So through multiple elimination process, they were able to identify about 842,000 individuals, unique patients that are low risk for the cardiovascular and pulmonary disease for the first cohort. And similarly, they did for the ECG cohort as well as the pap smear cohort. So they're able to identify all these patients as a potential participants for their subsequent analysis. And then they did the propensity matching methods. So this is some of the characteristics before the matching. So each column is showing 3 different cohorts. So the first cohort, when they're looking at the patient specific demographic information. So this is the standardized difference we're talking about. So before the matching, when they're greater than 0.10, that means there is a great imbalance in terms of these two different groups, screened versus not screened. They're very different in terms of their makeup. So vice versa in all these parameters, a lot of these are having significant difference in terms of distribution in the 2 different cohorts. Sorry, let me go back. And you can also see there are number differences as well. So the screened is only 21,770 and versus non-screened. Not screened is the majority, right? So among all these majorities, they're able to find the equivalent matching pairs to compare with the screen group and after the matching process, okay? So this graph just shows the patient factors. And then they similarly did the physician covariant distribution before the matching process. They're also showing a lot of these factors are playing a role in the distribution, including like the ones I have mentioned, years after medical school training, gender, etc. And these are the billing group covariant. So one way to make sure they're matching properly is after the matching, all these standardized differences are having less than 0.10. So they're balanced. So they also having an equal number of sample size in each of the group. Okay, so this is for the physician and billing group info. So next I'm gonna go show you the data results, which is the most important piece of this data, or the main message from the article itself. So they're looking at the primary outcomes. It's a busy table, but I'm sorry. Let me just break it down to you. So looking at the top top third is looking at the chest X-ray cohort. So we're looking at one of the three primary outcomes, either outpatient pulmonology visits, bronchoscopy, or the abdominal and thoracic CT scan. So when we're looking at the relative risk difference, that means the risk in the screen versus the risk not screened. So how I interpret is like in 100 patients, there is 0.87 more chances of patients getting screened to have a outpatient pulmonology visits compared with the group are not screened. So the 0.87, it's almost as like one more, but not quite there yet. And bronchoscopy, given that's the very invasive procedure, you can imagine that wouldn't be as more prevalent compared with just the clinic visit. So it's also showing here is slightly more in the screened versus non-screened. But all these, the third one, the CT scan, is actually almost as 2 times or 2 more of the tests compared with the reference. The groups are not getting screened. So all these, although they're having varying degrees of risk difference, but they're all statistically significant. How clinically significant it is, I would say they all are clinically significant as well, because you have to, get the test subsequent visits scheduled. It takes a lot of effort and energy from the clinical staff, physicians, as well as your insurance company, your payers, also patients' anxiety and not knowing what's going to happen. So I mean, it's not trivial. Let me just say it that way. And then if you look at the ECG group, it's also a similar story, but these are having higher risk differences compared with actually the X-ray group. So you except the cardiac catheterization, which is an invasive testing, the outpatient cardiology and echocardiogram, as well as the stress test, they are having a much more increased risk, a much more increased probability in the screen compared with the not screened. Okay. And for the pap smear group, so we're also seeing all 3 subsequent testing cascades are having increase in the screen versus non-screen. Given the repeat PEP is showing the highest risk difference, which is not too surprising, because a lot of based on the pap smear screening guidelines, a lot of the times when there is an initial abnormal PEP, the next step often likely is the repeat PEP. Okay, so I'm just highlighting the risk difference as an example, but if you're looking at the relative risk, it's showing the same story, same message, you're just showing a different number. This is more of a fold change. And if you look at the attributable risk fraction, so you're saying how likely are these subsequent care cascades are attributable because of the initial screen. So you're seeing this in this group is more than 60% across the board. This is also across board more than 60%. Maybe the gynecology visit is not as high as the other 2, but these 2 are more than 80%. Okay, so they are more than likely attributed by the initial index screening. All right, so this is the primary outcome table, and then they are further looking at the secondary outcome table, which is looking at more extreme care scenarios, whether they're getting procedures, they're getting hospitalized, ED visits, and death. So just know that these events are relatively rare, but they're not zero. And so they're looking at up to 1 year out from the initial index screening. So, and the ones I highlighted in the red is showing a significant difference. So let me just read to you some of the occurrences in these events. And though I'm telling you they're rare, but let me give you the exact numbers. So, so in the chest X-ray cohort, there are about 19 patients had underwent pneumonectomy or lumpectomy. That's less than 0.1%. And the ECG cohort, there are about 512 patients. That's about 0.2% of patients did have a coronary revascularization procedure. And in the pap smear cohort, there are about 55 patients. That's a 0.2% had undergone a hysterectomy. Okay, these events are rare, but like I said, they do exist. So I think the only outlier is the death occurrence probability in the pap smear group is actually better, or I mean less in the screened group versus non-screened. It's not entirely sure why that is the case, but all the others are, sorry, am I saying it right? So the ones in the red are showing a higher occurrence in the screened versus non-screened, except in the pap smear mortality group. Okay, that's correct. Okay. So yeah, this is all pretty much what the paper has shown. And in conclusion, they were able to say, yes, these low value tests are associated with more care, more referrals to the specialist, more diagnostic testings, more procedures. So I think this is important in terms of we're using a cohort study from real life or real world data to demonstrate that there is this association. And I do want to emphasize some of the limitations of this study. They are using an administrative study that they are aware that they don't know exactly how these patients present in those visits. So they assume those patients are really asymptomatic at low risk. And because without the clinical context, it's hard to absolutely be sure that these are not a low value screening test. So we don't, and they do acknowledge that there is no clinical history or physical exam information available for them to incorporate in their data analysis. And sometimes they also mention that these downstream testing cannot be definitively attributed to the index screening test, because some of symptoms might have occurred between an index testing and within, like, say, the 90 days versus the 1 year downstream. It's possible some other events could have happened. So that's something they say they cannot exclude from the outcome. And then also the test results from the initial index testing are not available for us to interpret whether these are actually really at that point indicated, or versus it's unlikely to improve their outcome from the initial test. So these are the limitations that I think the authors did acknowledge in their discussion, which are in complete agreement. I think one things that the study trying to minimize all the baseline variables playing a role in how these patients are initially getting these tests, but those factors do influence how, you know, how these tests, how prevalent these tests are getting ordered. So in order for us to make a global behavioral change in how we practice, how to eliminate these low value testings, further investigation on those aspects are very important. So next slides, I'm gonna just kind of, I kind of talked about this already. So kind of discuss with everyone to see what you all think of, why are these, what are the possible drivers or barriers why these low value tests are still frequently ordered. If you have any input, or I don't think it's a frequent occurrence, at least in our family health center practice, you know, because the newer EMR always asks us, what are the indications? Why are you ordering these tests, right? So there's always a specific diagnosis associated with these tests. So it's not as a frequent event happening in our practice, but it's still relevant. What can you think of might be the factors are that making this change hard in the global scale? If you don't mind chiming in. I mean, I listed a few in there, but if you have any other.
This is Dr. K.
Yeah.
Can I talk?
Yes.
Okay. So I think one thing that might drive some of this is the idea that we should get a baseline for if we need it in the future. So in particular, EKGs, I've seen people say, well, let's have a baseline. So if the patient comes in a couple of years and they have symptoms, we can compare their EKG at baseline. However, there have been studies that suggest that it's not a useful thing to do.
Yeah.
The other thing is sometimes specialists will recommend we get tests, but again, they're not thinking about it from a primary care standpoint. 20 years ago, neurologists were advocating that anytime a patient presents to your office with headache, you should be getting a head CT with contrast. This was pre-MRI days. And when they looked at this in primary care settings, those studies were almost never positive. They were almost never abnormal. It was a huge waste of money. But from a neurologist standpoint, they had a much higher hit rate because the primary care doctors didn't refer all the negative people to them. So it made more sense from their standpoint. But they were giving primary care doctors this false idea that we should be doing it all the time.
Yeah. Yeah, those are a really good point. I think we need more evidence to say whether they are affecting the outcome or not. And then we will have a better idea. We think we're doing something good in the long run, but in reality, we don't know. We don't know for sure.
Dr. Shi, Dr. Ramos put in the chat about liability and fear of missing something as a reason.
Yeah, so I have, I mean, to be honest, when I was first starting as an intern, sometimes I do panic of like, what if I don't catch something, right? That's a very valid physician perspective. And also there a lot of times we feel like more is more, and you know, you want to get, when people say routine tests, we get a baseline, or there's no such thing called routine anymore. I guess if there's no benefit of doing it on just the regular habit, just order set, that type of thing. But there's also sometimes one patient requests, can I get an X-ray? Can I get an EKG? Can I get a urine analysis? So that sometimes patients feel like, I need to get that. And then if you say no, and then they feel like, oh, are you rationing the care? Or are you not, I mean, patient satisfaction, or just not knowing this might not, in the long run, might not do any good for them or help change any outcomes for them. So there are a lot of things we can consider.
Okay, but you need to be learning how to, as a resident, you need to learn how to say no to patients sometimes.
Yes,
right?
Very important. So we need to be equipped to have those discussions, education and discussions with the patient. telling them what our risks are, what are the benefits are. And I think one very important aspect of this is at the heart for the inertia or the behavior change, although those recommendations are out there, is from the healthcare system point of view, the fee-for-service model. A lot of times, although these recommendations are out there, by following these recommendations, they're now generating more revenue from that standpoint. So there's not a lot of incentives for some providers, at least in those type of practice, to follow through on these recommendations. So there was one study that were comparing in Canada as well as in US, they're recommending against screening of vitamin D deficiency. So they were looking at a policy change in the Canada, I think it's 2012, when the government or the healthcare system decided not to reimburse these tests. And then that made a huge impact, much more significant impact compared with just choosing widely the global general recommendation standpoint. So, I mean, there are a lot of other things we need to consider for these changes to happen in more of a bigger scale. So that also kind of emphasized the value-based care, how cost savings would be important for the whole healthcare system. So there are also some interventions these were proposed in the commentary article with this initial paper. So these are some of the things that the author had proposed to kind of what are the next steps we can do to help these quality improvement efforts. So better characterize these testing cascades and the outcomes of the tests. So like say EKG, what improper or low value EKG tests, what are the subsequent care cascades are, and what are the implications involved. So better characterization of these cascades, and we'll be able to tell further whether these efforts or these downstream events are helping the outcome or not. So characterization is very important, and reporting that accurately. And furthermore, trying to find out the drivers for the low value testing like we were talking about. And then lastly is the efforts that we need to emphasize on coming up with some innovative, rigorous test interventions to reduce the low value testings. So a lot of things were actually, I can see is happening even in my practice. There are a lot of those clinical decision support tools in the EMR. And there are some practices, especially in the managed care or the ACO share saving programs. So sometimes they run those metrics for each physicians, right? So they will identify their physicians, how you compare with your peers, how often are you ordering these? Are these indicated? Are they making any changes in the patient's outcome? So by comparing these and giving feedback to personal and peer testing rates, that will be another approach that some of the authors had touched upon, how we can make this a bigger change and big impact for the overall delivery of care. Okay, I think I'm gonna move on to the next slide. This is another article Dr. Wiemers and we were able to find. So the study I presented is a Canadian study. So there is a similar study which is looking at in the United States for older individuals getting Medicare annual wellness visits. So these are older individuals, and they're looking at some low value testings that included urine analysis. I think there's a EKG as well as TSH. So it's a similar story. So these low value testings in those annual wellness visits are also associated with higher or associated with testing cascade, additional care, and additional spending for these beneficiaries for Medicare. So it's a kind of a similar study, but they're looking at other variables may influence the outcome. So they were able to identify that these patients who are getting those cares are more often are slightly younger in the cohort, although they're over 65, but more likely it's under 85. They're more likely to be white and living in the urban high income areas. So on average, they're estimated to be 6 cascade attributable events per 100 EKG recipient and 5 events per 100 urine analysis recipient within the 90 days after the index event. So it's a kind of similar study, but they're looking at further what factors are contributing to this difference. So lastly, very quick, I'm just gonna highlight some of the AFP choosing wisely recommendations. There are a total of 20 recommendations in the AFP adopted recommendations from the choosing wisely as a global internal medicine recommendations. So included in there is the EKG. I just want to read it out. Don't order annual EKGs or any cardiac screening for low risk patients without symptoms. So this was already there since 2012. Okay, and then similarly, this is for the Pap smear. So don't do Paps for women younger than 21 or older than 65 if they have low risk for cervical cancer. So there's no specific ones for the chest x-ray. And also, I just want to go back to USPSTF is also mentioning for adults with low risk of cardiovascular events, its recommendation is D, it's do not recommend to do having an EKG as a screening. The ones for intermediate and high risk individuals, it's insufficient data to support the need for EKG. So that is all I have for you, and here's my reference. Any additional questions we haven't?
Yun, I just wanted to make a point in that I think this is a timely topic right now.
Mm-hmm.
Anybody who's been paying attention to national events may recall that a few weeks ago, the CEO for a company called Theranose was convicted of fraud. And what she was claiming she could do was she had a technology that she could do 200 screening tests with a small amount of blood. And this she was financially supported by big name people. And my point is we should not want her to succeed and do 200 screening tests on totally asymptomatic people, right? Because if the normal range for a test is defined as 95% confidence interval for normal people, healthy people, that means out of 200 tests, we should expect 10 abnormal tests to come out in healthy people, and that would create a huge cascade of care. So we should actually be grateful that she did not succeed.
Thank you, Dr. K, for mentioning that. So a lot of times you feel like, oh yeah, I haven't been ordering those, but you know, a lot of times we're not the ones starting it. We might be in the middle of the cascade. So it affects every physician in some ways.
Dr. K, this is Byron, Dr. Hepburn, Byron. You know, the other great example is I've seen it and I've received it in the mail, advertisements for whole body ultrasounds, you know, which is definitely not proven to be of any utility whatsoever. So all of you will encounter this in your practice. Your patients will come to you and you'll need to give them sage counsel about why that would be actually detrimental versus beneficial, but they're being hounded to do so.
I think the hard part about that is knowing educated individuals that aren't medical. It's hard to explain harms versus benefits. Well, you found something abnormal. Why would you not want to find it? No. And then if you take our population that sometimes has very poor health literacy, it's a very hard concept to understand. Like, you found something abnormal, why would have you not wanted to do it? And so I think that's the challenge of being able to talk to your patients for their understanding that it's not that they're not worth the effort to go find this thing abnormal, but that you're actually more likely harming them. And I think that's just such a hard concept. And I think that's why we end up in this dilemma sometimes too.
Yeah. Yeah, I think Dr. Wimmers, you're referring to in the middle of after initial screening test was there's something we found, right?
Or like even just on Dr. Hepburn's comments, I've had so
Oh,
many
yeah.
patients come in and their insurance is offering them this
Oh,
ultrasound
yeah, the
screening.
insurance part.
I mean, it's, yeah. And so then you're trying to explain to them, they get this free benefit. They might find something abnormal that they wouldn't have found otherwise. Why would it not be a good thing? That's just
Right.
such a challenging concept.
Yeah. Okay. Any other questions? No?
See any other questions there? So thank you, Dr. Shi, for your presentation and Dr. Wiemers for precepting. And also thank you everybody for joining us. The link is there if you can help provide us some feedback for Dr. Shi, and we appreciate everybody attending. Thank you so much.
Thank you, Nicole.